Good morning, everybody. I'm here to talk about cervical deformity. Thanks to Greg and Hani uh, and everyone for inviting me here. I really appreciate it. All right.
Thank you,
So
Eric.
we're going to talk about cervical deformity. Where are we now? I want to thank Virginia Lavage. I unceremoniously stole several of her slides for this talk. So here's a patient of mine, 53-year-old female, complains of neck pain, difficulty walking, and on exam she's hyperreflexic, has a positive Hoffman's and full strength, but has a significant cervical deformity in both the coronal and sagittal plane, with a significant amount of cord compression, some cystic changes in her upper cervical spine as well. And so the question is what do we do with this? And so we know that the shape of the spine has changed over time. In over 7 million years, we've seen a difference in what it looks like today versus what it looked like many, many years ago. Whoops. And as we've changed, the upright posture requires controlling the skull and creating a sufficient amount of cervical lordosis to compensate for the other spinal curvatures, including increasing thoracic kyphosis and lumbar lordosis, which then allows us to stand upright and invert the pelvis in a way that the hips can be covered and we can walk in an upright, comfortable position. We know that things have changed over time, and cervical lordosis has also gradually increased over time anthropologically as we look to see what that normal lordosis should be. And so really trying to understanding how much lordosis should there or should there not be in the cervical spine. We've all been taught that it's supposed to be lordotic, but how lordotic and how much do we need to keep is important, particularly when we think about fixing it, because we need to know what our goals are. And so we know that the lordotic curvature is important. We've had a lot of discussion on it. We've had a lot of information. We've talked about loss of lordosis with increasing alignment. It gives us problems and creates a vicious cycle of abnormal forces and progression deformity. And furthermore, we know that with increasing kyphosis, we have increased cord compression, and with increasing lordosis, then we have decreasing problems with cervical alignment and particularly with spinal cord function, which is ultimately what we're after, is making sure we decompress those neural elements and realign things appropriately. So based on this evidence, we know that cervical kyphosis is a deformity, and how much a deformity is it? But it's not always that simple. And what's a natural shape of the cervical spine should be in people that don't have problems. And if we look at what it looks like in other segments, sometimes the cervical spine can be quite straight. So here's a relatively straight patient who can adapt to their overall alignment, mostly to make sure that they put their head in a functional position. And so cervical alignment is just the top part of their overall alignment. And really, we need to take it in context with the rest of everything that's going on. And with deformity or with abnormal segmentation in the cervical, in the thoracic and lumbar spine, the cervical spine needs to compensate for that to get the head in a good position. We really want to maintain horizontal gaze, and obviously, this is important to make sure that we can see where we're going and interact with people, and that's really what it's there for. And the thoracolumbar alignment, and particularly the T1 slope, really dictates what that cervical lordosis needs to be. If we look at the radiographic assessment, we can come up with this chain of correlation looking at pelvic incidence is related to lumbar lordosis, thoracic kyphosis, and ultimately cervical lordosis, so that all of these are interconnected. Again, this isn't not too surprising, right? That everything is affected by everything below it, and ultimately to allow that head to be in a straight position. And there's some reciprocity between the curves, C2 to C7 versus thoracic spine. And really, again, it's that T1 slope or C7 slope, whichever one you want to think about. But that really dictates what that cervical lordosis has to be to get things appropriate. And it's sort of the pelvic incidence of the cervical spine is really that T1 slope. And you can see with changing slope, we need changing amounts of lordosis. From the patient on the left, who has a relatively flat T1 slope, therefore relatively lack of lordosis in the cervical spine. And as that T1 slope increases, you see increasing necessity for cervical lordosis. And again, even when the pathology isn't necessarily in the cervical spine. Horizontal gaze measurements, we look at the chin vertebral brow angle and surrogates like McGregor and slope of sight. All of those are important to get a sense about where we are in space and making sure that the head can look at things easily. And really, we're looking to make sure that there is not excessive lordosis or kyphosis in the C1-2 junction, because that's the last compensatory level. And that chin brow angle correlates with disability. You want it to be down a little bit more than you're up, and you want there to be enough motion so you can have a downward angle, somewhere between 3 to 5 degrees, so you can see where you're going, you can watch your feet, and make sure you can still look up enough to interact with people when you're walking past them. And so how much lordosis do you need? And so really, if the T1 slope is less than 17, then the normal spine actually can be kyphotic or can be straight. And so that gives you a sense about how much you need or don't need. And again, here are just some examples of looking at an overall kyphotic spine when that C1 slope is really, really low. And so again, holding that cervical spine in normal alignment, it's really getting the head and eyes in normal alignment. And that's the most important bit. Cervical spinal alignment, if we look at normal volunteers, what does their cervical lordosis look like? And with increasing age, we see that they also have increasing lordosis, and it changes slightly as we get older. The regional changes, you get loss of lumbar lordosis, increasing thoracic kyphosis. So you increase the T1 slope, and with that, then you need to have an increasing cervical lordosis to maintain that horizontal gaze. And all these things, all these compensatory mechanisms kind of correlate with one another as we get older and as we have as we flatten our lumbar spines in particular. And so lordosis is affected by age. And you can see here's what is normal, and the answer is, well, normal may change as you age and as you get older, because it needs to maintain that horizontal gaze and all of that, which is why the flexibility in the cervical and thoracic and lumbar spine is so critical. And so we need to be careful about how we restore alignment and holding things, particularly when we make things rigid and we change things dramatically. And so if we look, this is a morphologic study of a lower cervical curvature looking at asymptomatic subjects, and you can see lordosis greater than 10 degrees was 29% of patients, less than 10 was 39, and kyphosis was in 20% of patients. And so kyphosis isn't necessarily pathologic in and of itself, and having some amount of kyphosis, particularly young with a low tilt, may be appropriate. And so really only 30% actually had lordosis greater than 10 degrees, which is what we've all been kind of taught as being normal necessarily. So C2 to C7 lordosis in asymptomatic patients, you can see here that, again, there is a normal amount of lordosis, but that not everyone is strictly lordotic. And again, 40% of patients have an actually kyphotic spine, indicating that kyphosis may in and of itself not be a pathologic syndrome. And again, if we look at these with a high TL sacral slope with cervical lordosis, you can see that there are a significant number that are straight. And so with those straight spines, that means that half are going to be lordotic and then half are kyphotic. And so there's really is not necessarily right. So, what is cervical deformity if kyphosis is normal? And really, it's about a disability in the amount of deformity that you have. We know cervical deformity is disabling, and it really depends on how we define it. And so, if we look at radiographs, and so these are some X-rays of people with kyphosis and with cervical disease, what is a deformity? And we can separate them into different bits. And so, if they have just amount of cervical kyphosis, but it's overall fairly sweeping, and it's probably not really a deformity. If it has this long sweeping curve, then maybe it's increasingly deformed, and you can imagine that this is causing more stress on the paraspinal musculature. And then when it's fixed and can't be passively corrected, then that probably is a deformity. But again, cervical deformity is much more than just radiographic parameters. It's also an evaluation of the patient and understanding what they are symptomatic from and for. And cervical films can be misleading. So if you see a very high T1 slope, and I looked at this several years ago, we looked at if we found a T1 slope that was greater than 23 degrees, that we had increasing risk of having problems in the lumbar spine. And really, where does that problem come from? And the answer is that there's going to be a thoracic kyphosis, which then puts the T1 slope in a poor area. And so if you only get cervical spine films with a high slope, if you see this slope, again, 25, 22 degrees, make sure that you get long films to get a sense about what else is going on. Again, it may not be what you necessarily treat, but you at least want to understand what the problem is in terms of their overall alignment. Drivers of deformity, thoracolumbar kyphosis or junctional kyphosis, cervical spine, is this really the isolated disease, or is this really more a consequence of those other alignment? And again, high alignment with pelvic retroversion, there's really a lot more stuff to do. And so if we remove that compensatory mechanism, now you can see that we're having worsening sagittal malalignment. And now we think about, boy, how do we correct this? And actually, if we look, most of the problem here is not actually a cervical thoracic problem. The answer here is a thoracolumbar problem. And so be careful that you don't just focus on the numbers or just focus on one location, but rather think about the entirety of the spine if you're going to think about doing some sort of correction. So key parameters and principles, cervical curvatures are important to understand, as is the C2, C7 plumb line, as is the focal alignment. So if they're focally kyphotic or focally angulated also is important. And then in terms of the overarch of motion and then the maintenance of horizontal gaze. And so we also need to differentiate cervical deformity from mild cervical disease. And so we looked at, this is a study that Virginie did, looking at discriminant analysis, what differentiates severe cervical deformity from mild or no deformity, and then what were those different presentations of disease. And we looked at these to try to sort out which ones had significant deformity. And what we looked is we found that really the things that matter the most, it was really the lateral C7 cervical SVA, the slope, and then the extension, the amount that the cervical spine was able to passively move to get into the best position was important. And then max kyphosis and the extension and the kyphotic levels. And if we looked at that, 87 cases were correctly classified with those parameters, but that didn't mean that all of them were classified by that. If we look too at the focal deformity, is that it's not just in one location, but you actually have to look and see what's happening within the curve. And with the extension, you can see here's the lateral alignment extension. And we essentially categorize people into three different categories. Those that had focal deformity, that had one angulated or two angulated areas, but that had maintenance of cervical extension. Those that had a flat neck, and so these are kind of the dropped head syndrome folks with poor muscular alignment, but could be passively corrected. And then those that had very, very high T1 slopes and had a significant cervical thoracic deformity and really more of a thoracolumbar problem than cervical. And so cervical might be compensatory. And the advantage of these is that while we can start looking at how to classify these, it can also help us think about how we might want to think about fixing them. And so if we look at the alignment and apex of location, we group them in these three groups. So the flat necks had cervical lordosis, but wasn't enough. Group 2 had a focal deformity, but the C7 T1 slope was pretty close to right, particularly on those extension x-rays. And then cervical thoracic deformity, it really didn't matter because you couldn't change the alignment because the problem was really happening outside the area of the film. And then these did help us think about how we would do surgery. And so if you just have this flat neck deformity, these were typically posterior fusions alone, where you could do an extension x-ray. And then with the maintenance of a normal alignment on extension, that really helped us think about whether or not you needed a front, back, or back only. If you had focal kyphosis, you could think about doing an anterior only surgery or an anterior posterior surgery. Cervical thoracic ended up being fusion in the thoracic spine and often needed some sort of 3-column osteotomy for correction. And so those can then start to help you with guidelines. And when you think about seeing people with problems and think about how you might want to start treating them. So again, focal deformity, radiographic presentation, they're kyphotic in the neutral, but extension, they can improve things, but that focal kyphosis really doesn't change. The T1 slope is normal, so they're able to maintain a normal gaze with a straighter kyphotic spine. and the SVA is usually normal. And again, these can be treated either with anterior surgery or interposterior surgery by realigning that focal kyphosis. Here's an example of that. You can see focally kyphotic, but with extension, the kyphosis doesn't change, but the rest of the cervical spine can. Cervical thoracic deformity is kind of the next easiest one to think about. And so T1 slope is very high, and so it's a large slope where they have similar lordosis in neutral and extension because they're maximally extended, trying to hold themselves upright. And they have this large interalignment with hyperextended C2 to C0. And so again, a maximally compensated upper cervical segment. And mostly these are coming from junctional disease. So PJK is the highest driver of this problem. And really, as you can imagine, the fixation doesn't need to be into the cervical spine. It needs to be in this upper cervical segment to renormalize that T1 slope. And that's going to allow the head to then be better balanced and take less stress off the cervical spine. Again, that's what that looks like. So those are exactly the same. And you can see that hyperextension of C1-2. And these are the folks that are going to end up with Dens fractures or C1 arch fractures as the occiput impinges upon that C1 arch and into the C2 arch. So, and then finally, then you get these flat necks. And the flat necks have a T1 slope as neutral is pretty normal. The CVA is high, but they can correct nicely with extension. And with that nice extension, then you know that this is a passively correctable problem, probably more of a muscular issue or a sarcopenia issue, in which case this can be fixed with posterior-only instrumentation. And this is why extension x-rays or supine x-rays are so important. You can see here significant deformity, but when you get them in the extension or laying down position, you can see that the vast majority of this improves, demonstrating the flexibility of this curve, and then also giving you a sense of the muscular integrity, and really that's the biggest issue there. Again, high SVA, but C7 SVA is normal, and really the issue is all in that cervical spine. So we can define it by a combination of these parameters. And again, these flat necks, focal deformity, and cervical thoracic deformity. And then really the extension is the critical piece. And we wrote a paper several years ago looking at postoperative extension laterals were associated with osteotomy type and approach. And really the amount of correction that you were able to get told you what you needed to do. And so if you can extend normally and get to a good position, then you don't have to do an osteotomy. If you can't extend to neutral, then you need to think about doing an advanced procedure, either an anterior posterior procedure or some sort of cervical osteotomy to get things lined together properly. And the final postoperative alignment at 3 months was comparable to your pre-op extension lateral. And so that really was an important piece of thinking about what you were going to get and how you were going to get it. So what's next? What do we need to know in the setting? So we need to know about the chin vertebral brow angle. We need to know what the T1 slope is and get a sense of what that is. We need to look at the focal alignment and look at the cob. And then we need to understand the regional alignment to understand where we need to do our surgical correction, whether or not that can be in the cervical spine or needs to be in the cervical thoracic spine to think about getting things aligned together properly. And then finally, we need to understand whether or not this cervical spine is flexible. And so an extension lateral X-ray is a critical part of the evaluation of any patient with cervical deformity, as are 3-foot long standing films. You really need to understand the whole bit of it. And there's lots of other stuff. And so we need to continue to think about all the McGregor lines and occipital cervical slope and all the rest. And those are all important, but those are going to be helping us refine the analysis. But I think we have kind of the general feeling, at least, that those 3 types and those 3 shapes are probably the most important ones to understand. And so cervical alignment can be decomposed into different steps. You want to look at the alignment without numbers to get a sense of what things look like and understand what the shape of the spine looks like. You want to identify the location of the deformity. And so in this case, this is a cervico-thoracic deformity. And so we can identify that. And then we identify the compensatory mechanism. So is the patient maximally hyperextended? They are. Do they have high C2, C7 SVA? And they do. And so, and we need to then think about where the alignment needs to happen. We clearly are just in the infancy of understanding cervical alignment. We need to understand the bone and joints and morphology and muscles. We need to understand how much these variation changes with age. We need to understand fatty infiltration, sarcopenia and aging, and its impact on alignment and disability. And the other thing is we haven't even talked about the neurologic function and where neurology is really driving how we think about when we want to intervene on these patients, and certainly the thing that our patients care about the most. They care about disability, but really disability in relation to its neurologic components is really an important thing. And maybe a cervical deformity questionnaire is probably what we need to think about, next. So if we take this all together and we take a look at our patient, and so here's our patient that we saw in the beginning with this cervical kyphosis, fixed deformity, and a significant disease. And so we look how we think about fixing it. So the T1 slope is relatively low. The cervical spine is maximally compensated. There's very little motion on extension, and it's stuck in kyphosis. So this is a focally kyphotic patient. And what we need to do is we need to decompress the canal because she's myelopathic. That's the most important bit. And so we want to do both of those things together. And really what we need to do is remove this kind of either fused or malformed vertebral body and take the pressure off the spinal cord and get things realigned. And so, again, this is a focal deformity cluster. So we do an anterior approach. We do a decompression and remove the vertebral body and compression on the spinal cord. We place a strut graft, but don't lock things in place. We allow it to become flexible, and then we do a posterior approach and then pull things back into the right correction, pivoting off of that graft anteriorly to get things lined together properly. And here's our final alignment where we're able to maintain her horizontal gaze, and most importantly, we're able to take the pressure off the spinal cord to get things to line together properly. And you can see here's her upright X-rays where her gaze has been maintained. And again, we've been able to fix her deformity by really fixing her myelopathy. And again, that was her big issue and big problem. And this is what she looks like a year later. So she gets resolution of her pain. She has a little bit of mild dysphagia from that anterior approach, and we're able to fix that focal kyphosis here in that mid-cervical spine. And by doing so, normalize the T1 C1 occipital slope, and then take the pressure off the spinal cord. And again, that's the most important piece. The cervical spine is a unique part of the spine. It cannot be investigated as a standalone segment. You really need to look at all of those things together. The curvature of the cervical spine is complex with a lot of variability, and it can increase with the presence of deformity and with age. And really think about those three clusters, again, which is going to be the flat neck, the focal kyphosis, and the cervical thoracic deformity. And those will help you when you're trying to categorize them into different locations, and then start to think about a surgical management. And if you don't remember anything else from this talk, please get cervical extension X-rays so you can understand the passive correction of the deformity, and that will help you when you think about surgical management and surgical intervention. All right. And so it's really looking at that cervical curvature rather than cervical lordosis and make sure it balances everything else. That's it. Did I make it on time?
Awesome, Eric.
Masterful. 6:59.
Yeah, perfect.
All right,
Good to see you, Bob. Thanks for having me.
Yeah, you bet. Thanks for doing
I don't know if there's any questions or if you guys are ready to wrap it up.
I'll throw one out there just because I think we struggle with it a little bit, especially with people learning deformity and how to assess it in the setting of a broader spinal pathology realm. But in the lumbar spine, as you know, there can be a perceived deformity in the setting of neurogenic change in posture. And I think we see the same thing in cervical spine. So
agreed.
In your experience or practice, how do you vet those where you see a patient that's got cord compression and may have what radiographically looks like a deformity, but may actually just be involuntary muscle posturing of the cervical spine to alleviate cord compression, and then manage the decision making about deformity correction versus alleviating the cord compression, or both?
Thank you for the softball question.
Yeah, no problem.
That's hard, right? Because and it's hard to figure it out. And it's not just so you have some obligatory kyphosis because that takes some of the pressure off the canal. So that does help you. You also have some obligatory kyphosis when you're in neck pain. And so people will stand with their neck forward flexed. I do think that you have lots of hints about what things look like. So if you just look at the neutral, and again, you showed this nicely with your flexion extension x-rays, that we can't, in the cervical spine in particular, because there's so much motion, we can't get fixated on just one static image. And looking at that extension lateral is the most important image for me in terms of thinking about flexibility and where the spine can get to. And I also look at the arc of motion. And so if your neutral lateral looks like your extension x-ray, then the answer is that you are spending all your time maxed out in your extension location, and doing something decompressive only might be risky because you're going to tend to come to that midpoint. Same thing if you're so I really kind of get a sense about where they sit in the middle of that piece and their laterals. You also have, though, the supine x-rays where you can get a good sense about what things look like when you take the pressure off. That can also be helpful. And then sometimes you can do things like epidural injections, take some of that inflammation, irritation out of the way, and then look at what the spine alignment looks like. This might be heresy also, but I think you can also, I'm the reason cervical deformity is such a hard thing to focus on is I think when you and I see a patient, I focus on the neurology much more than I focus on the alignment, in particular with the cervical spine. And I'm much more apt to do a flexible decompression and do a laminoplasty than a fusion. And even if the laminoplasty doesn't work or they fall into kyphosis afterwards, then the revision isn't that big a deal. And so I really focus on the neurology and the cervical spine much more often. And I might do a single or two-level ACDF, get things in the right place, and then think about a laminoplasty or something else rather than necessarily doing some humongous cervicothoracic fusion unless I have to. And the problem is then you get DJK and you start chasing yourselves. And then I've certainly, unfortunately, played that game with more than one patient. And you can end up with pretty big C2 to pelvises for what you thought wasn't that big a deal cervical deformity.
Great. Yeah, thank you very much. I totally agree with you that I found that I'm more reliant on the supine, the relaxed imaging, because I think that takes a little bit of the pressure off the neurogenic listing or postural changes that occur because of it upright. So it helps for sure.
Yeah, totally agree. Good. Anything else or get out of here?
Fellows? Dave, Mike, anything? Crickets?
Yeah, I mean, classic fellow question with logistics. Can you talk about how you get the appropriate alignment intraop, like extension, if you're using a Mayfield or bivector traction, or what your preferred method is?
Yeah, it's hard. So I've done both. I don't love bivector traction because when I'm putting screws in and fixing an alignment, the damn head moves around too much for me, so it makes me nervous. And so if I'm like putting a screw in, I'll see that the whole head will sag down and back and up, and so I prefer Mayfield. We have a Levo head holder, which is that articulating head holder that you can grab onto and manipulate. And I will typically put the head in kind of a military tuck position, then do the decompression instrumentation, and then do the realignment while I pull the head into a more extended position. It's like most things, you want to measure twice and cut once. Intraoperatively, I look at the chin brow angle, I look at the C1-2 articulation, and get a sense about what my goals are. And that usually helps me out a lot. The cervical spine in general, I'm always fighting to try to get enough lordosis. I'm trying to think if I've over lordosed someone in the cervical spine. It's pretty hard. And so just getting them back to neutral or a little bit lordotic usually is my goal. And I want to make sure that I'm really paying attention to what that T1 slope is, because that'll help dictate then what that lordosis is. So the answer is have a goal. Having a goal is the most important part. And then measuring it intraoperatively, I will get lateral x-rays or a lateral scan to make sure that I've achieved what I want to. And if you need to change it, then you change it intraoperative when you're still looking at things. I think the hardest thing is when you have to go to the skull. And so if you go to the skull, then you really lock in their chin brow angle. And that's when you run into trouble. And for those, you have to look at the C2 slope, and I'll look at the C2 slope in conjunction with the face to try to get a sense of where things are right. And I will often tell patients that, hey, we're going to lock things where they are and see how it goes. And if it's not right, then we may need to come back and change it. And so I might leave the rods a little bit long in the cervical spine, in which case it's a pretty quick open, distract, or compress to try to put the head in a better position if necessary. In fellowship, we used to actually lock people in a halo, and we would dial if we had to fix the skull, and we would extend or flex them until we got them where they felt comfortable. And then that's where we knew that was the right position for them. So that's also a trick if you're thinking about fusing to the skull.
Wait, I'm assuming that timeline's relatively short, like you're talking immediate post-op period, just doing a quick revision to
Correct.
distract. Okay.
No, exactly. While the wound is still fresh, and again, it's hard. No one wants to go back to the operating room, but you do want to get things right. And the key thing is the killer is looking down is okay. It's the ones that we get them stuck in that up position that they are really, really miserable. They have increased problems with swallowing. They can't figure out which bathroom they're going into. Disaster. So
stargazers.
Yeah, Stargate, exactly. So if you got to pick, again, somewhere between that 5 to 10 degrees, looking downwards, and that's usually pretty safe. Now, again, this is only if you go to the skull, because the rest of the time you're going to relax that O1 compensatory mechanism, and then or O2, and then they'll compensate for you. And relaxing that is an important piece of getting things right.
Awesome. Thank you.
You're very welcome.
Well, Eric, we don't want to tie your day up. Thank you so much for spending the morning with us.
It is my pleasure. Bob, great to see you as always.
Thank you,
Eric.
Thank you, Eric.
Appreciate it.
Thanks for inviting me.
Take care.
Bye, guys.
Take care. Bye-bye.